Welcome. We're about to tackle one of the trickiest topics in mental health nursing, somatic symptom and related disorders. My goal here is to make this crystal clear for your exams and, just as importantly, for your future clinical practice.
Okay, let's just dive right into the heart of the matter. You've got a patient, they're in real distress, their symptoms are completely debilitating, but every single test, every lab, every scan comes back negative. So what's the deal? Are they just faking it?
So first up is somatic symptom disorder, or SSD. And the absolute key here is to get past that question of, is this pain real? And really focus on the patient's genuine, overwhelming distress. That's our starting point.
Now, here's a really powerful way to think about this. Picture a fire alarm that's just blaring. The noise, that physical symptom which is usually pain, is real, it's deafening, and it's absolutely terrifying to the person hearing it. Now, as the clinician, we can see the sign that says, no fire found. But telling them the alarm isn't real, that just doesn't work. It's totally invalidating. So our job isn't to argue about the fire. Our job is to validate their terror from the alarm and then help them learn to cope with all that noise.
So what exactly are we looking for on the floor? The main thing is one or more somatic symptoms, and pain is number one, that are causing major disruption in their life. This has to have been going on for more than 6 months, and you'll probably see a long history of doctor shopping because they just feel like no one is listening. And let me be really clear on this because it's the most important point. The client is genuinely experiencing these symptoms. This is not faking.
And this is where the rubber meets the road, our communication. With just one sentence, we can either build a wall or we can build a bridge. The wrong way completely dismisses their reality, and boom, trust is shattered. But the therapeutic way? It does two crucial things. It validates their distress without confirming a medical illness that isn't there, and it immediately redirects them toward a healthy coping skill.
All right, let's build on that foundation. Next up, we have illness anxiety disorder, or IAD. With this one, the focus actually shifts away from a distressing physical symptom and lands squarely on the overwhelming fear of having a disease.
So, for IAD, I want you to think of a broken virus scanner on a totally healthy computer. The body is fine, right? The system is healthy. But the mind is just constantly running these obsessive scans, and it's flagging every single normal sensation, a little stomach gurgle, a minor headache, as a catastrophic, fatal virus. The whole system just gets bogged down by these terrifying false alerts.
Now, this distinction is a massive exam topic, so let's nail this down. With SSD, the main problem is a severe physical symptom. With IAD, the physical symptoms are super mild, or maybe even totally absent. The main problem is the severe, crippling anxiety about maybe having some kind of silent killer. And get this, there are two types. Some people are constantly seeking reassurance from doctors, while others are so terrified of what they might find, they avoid doctors completely. And that right there brings us to a classic professor's trap question. So, based on what we just talked about, a client with sky-high anxiety about their health refuses to get their annual physical. Does this mean they don't have IAD? What do you think?
You guessed it. If you thought it rules out the diagnosis, you just fell right into the trap.
And here's why that's a trap. That extreme avoidance, it's actually a classic presentation of IAD. Their anxiety is just so profound, so intense, that they avoid doctors at all costs because they don't want their worst fears to be confirmed. This avoidance behavior is a core feature for the care avoidant type, and it absolutely does not rule out the diagnosis.
Okay, let's shift gears to a really specific and often very dramatic presentation, functional neurological disorder. You might also know this by its older name, conversion disorder.
The best way to picture FND is like a blown fuse. Imagine a massive psychological stressor, like a really severe trauma, acts like a huge power surge to the brain's emotional circuitry. Well, to protect itself, the brain unconsciously just blows a fuse, and it cuts the power to a physical function. This causes a very real neurological deficit, even though all the wiring, the nerves, the muscles, is perfectly fine. So these are the signs you have to know. The onset is sudden, and it almost always happens right after a major stressor. The client shows up with a real severe neurological symptom. I'm talking paralysis, blindness, or seizures, but every single clinical test comes back negative. You might also see this thing called La Belle indifference, which is a really strange lack of concern about their severe new symptom. And I really can't stress this enough. The deficit is real to the client, and it is completely involuntary. They are not faking it.
Communication here is everything.
Accusing the client of faking will just destroy any therapeutic relationship you could hope to build, because this is an unconscious process for them. The correct approach is to validate it as a real illness and then immediately shift the focus to a collaborative recovery plan. We want to empower them to work with physical therapy to regain that lost function.
Okay, major shift here. Everything we've talked about so far involves symptoms that are unconscious, that are involuntary. We're going to make a huge pivot now to a disorder that involves conscious, intentional deception. This is factitious disorder.
Our last analogy is the arsonist firefighter. This is a person who intentionally starts the fire. They create, they fabricate, or they induce an illness for one reason: to get the attention and sympathy that comes with being rescued and cared for in the sick role.
Now, if you remember only one thing about factitious disorder, please let it be this. It is so easy to feel angry or manipulated by these patients, but you have to remember, the physical illness is fabricated, yes, but the psychiatric illness that's driving it is severe and very, very real.
And for safety, this is totally non-negotiable. When factitious disorder is imposed on another person, especially a child or a vulnerable adult, it is abuse, full stop. Your absolute priority is not to confront the perpetrator, it's to protect the victim. You are a mandatory reporter, and that means you must report any suspicion immediately. You are 100% going to see this on your exams, so let's lock this in. The difference between factitious disorder and malingering is tested all the time, and it all comes down to one word: the motive. In factitious disorder, the incentive is internal. It's a deep psychological need for attention and sympathy. In malingering, the incentive is external and tangible. Things like faking back pain to get a disability check or trying to avoid jail time. Okay, let's put it all together now. For this final scenario, you need to think like a nurse on the unit. What is your absolute first priority?
So you get this report: a 9-year-old kid with multiple admissions for low blood sugar that just can't be explained. But it only seems to happen when the mother, who's a nurse and very involved, is present. What red flags are going up for you right now?
Based on those huge red flags, what is your first, most critical action? What do you do right this second?
The only right answer here is to act immediately on the very strong suspicion of factitious disorder imposed on another. That means first ensuring the child is safe, and then, without delay, you make that mandatory report to Child Protective Services and to your hospital's internal teams. And remember, when you document only objective facts, never your accusations. Your first and most important job is always to protect.